Hello, everyone, and welcome to today's discussion. I'm Hamie Tawarson, the Executive Director here at the National Academy for State Health Policy, otherwise known as NASHP. And we are hosting this discussion along with the Robert Wood Johnson Foundation. Earlier this year, in the fall, RWJF and NASHP awarded Medicaid Innovation Awards to Medicaid departments in 6 states. It was fantastic at our annual conference to see and recognize all of the wonderful work these state leaders have engaged in. And the nonpartisan award really was designed to recognize states for demonstrating creativity, leadership, and progress in their Medicaid programs. And the recognition, I think, was important to all of us because Medicaid has faced significant challenges in recent years as the programs try to improve health outcomes for all the beneficiaries they serve. So celebrating bright spots and learning from one another is really empowering, and we're happy to lead that however we can. The 6 recognized states are Kentucky for streamlining enrollment, North Carolina for improving access to care, West Virginia for improving care coordination, Minnesota for addressing health disparities, Arizona for addressing social determinants of health, and California was recognized in the category of promising emerging initiatives. In the weeks ahead, we're going to continue to highlight the states that received an award through additional informal chats like this. You'll see a link to register for our next chat on January 10th with Kentucky and West Virginia, and you'll see that in the chat box now if you're interested. But today, I'm really excited to be joined by J.C. Cooper and Jamie Snyder, the Medicaid directors in California and Arizona, respectively, for a conversation about how they are taking a whole person approach to care delivery. We have 45 minutes, so this is going to be a casual conversation. Obviously, we won't be able to get to every detail about these programs and are going to hit the highlights. But I really think and hope that discussions like this spark ideas and creativity for other Medicaid programs across the country. So I hope you all will join with rapt attention and really please chat your questions as these 2 leaders talk about their programs. So I want to just get started since we don't have that much time today, and I'm going to begin with J.C. Cooper and California's CalAIM initiative. This is a holistic and integrated approach to Medicaid that's making it easier for people with the most complex needs to navigate Medicaid and connect with services that extend beyond traditional clinical settings. And as we know, California is an incredibly large state, so we're really interested in hearing more from Director Cooper tell us more about the CalAIM initiative, why it began, and what the general goals are. So we'll start with that. I'll turn to you.
Thank you. So CalAIM is really meant to be, it was designed to be a 5 to 7 year complete kind of reform of what we call Medicaid in California is called Medi-Cal. So if you hear me use that term, that's what we call it here. Was a transformation really for our Medi-Cal program. And one of the pieces that we really acknowledged as we were building this waiver is that, we really needed to make sure that we had a full continuum for all of our Medi-Cal beneficiaries, and we felt like there were some gaps and opportunities. So we had these amazing whole person care pilots, is what we called them in California, that had been going on for at that point 5 years, and we wanted to make sure we really learned from those pilots, the opportunities that were yielded. Because it was really around how do we think about the whole person? How do we break down some of the historical silos of healthcare to really make it feel integrated, even if it's not truly integrated, to be honest with you, because the way things work in California, and I'm sure other states have the same problem, different delivery systems are delivering different parts of the Medicaid overall benefit, right? But how do you make it more seamless and integrated for our individuals? So that was a key piece of it. So we wanted to look at delivery system changes, financing pieces, and really think about a comprehensive way we could do that. But we also knew that there were certain populations, very vulnerable populations, that had maybe been historically left out of the full continuum. For example, people experiencing homelessness. We didn't have a full continuum of care. The ACA expanded to, adults or optional adults. We didn't have a continuum. Someone who's admitted into a hospital, for example, who's experiencing homelessness, they don't necessarily have somewhere to be discharged to recover, safely, and to get the care that they need. And so we really wanted to make sure we were building a continuum for people across our behavioral health systems, justice involved, people experiencing homelessness, or just some of our most vulnerable, even with medically complex. So really big core piece of CalAIM. CalAIM it's very comprehensive, multiple initiatives. Today, I'm going to focus around our comments on the change that we're doing around enhanced care management and what we call community supports. And really, there is really about making sure that we are wrapping additional services around some of our most vulnerable. Longstanding, everyone knows that there are a number of kind of in care management programs that have existed for a long time in Medicaid and in healthcare broadly, high utilizer programs, et cetera. What we think is different around what we're building in California is all of the wrap services that complement those very complex populations. So people experiencing homelessness, the ones that I mentioned, but making sure they have what we call in California community supports wrapped around them. So it's kind of driving towards the social drivers of health. And we took a combination of things in our whole person care pilot, as well as things that are happening in home and community-based service 1915C waivers across the entire nation, and thought about how do we get that more upstream? How do we make that more preventive? How do we make sure that people are getting connected to that? Because one of our goals with CalAIM was breaking down the walls of healthcare. If healthcare was working for all of our beneficiaries, we wouldn't be here today. We wouldn't be thinking of these solutions. So we needed to break down the walls of healthcare and go to people where they are. So our enhanced care management benefit is not like complex case management, for example. It is meant to be in the community. So you're meeting someone in their home. If you're someone experiencing homelessness, it's a street-based team out there engaging with people. And you have to pay more and different for that, right? And then wrapping that with our community support. So in California, we put forward 14 community supports, and that includes things like housing transition services, navigation, deposits, sustaining services while somebody is housed, to do the liaison with their landlord so that they can stay housed. Because we know, based on lots of data, people get housed and then maybe fall out of housing, right? So how do we keep them there? We also are paying for transitions from skilled nursing facilities to into the home or community, similar to like the Money Follows the Person program, if you're familiar with that, but really getting it more upstream in regards to being prevention and broad-based across the state. Paying for things like caregiver respite. Huge data that shows if you allow for caregiver respite, you are going to avoid inpatient ER or skilled nursing facility pieces. Covering things like medically supportive foods, asthma remediation, sobering centers, avoiding that emergency room. So we really wanted to look at the full perspective, and make sure that there's a continuum of services for somebody, for all of our Medi-Cal beneficiaries, really making sure that it's a comprehensive environment. So we took a number of those. One thing I would point out before I go to other questions that we did is, some people ask us, all the different federal authorities, why did we pick the in lieu of services authority? And I think just to kind of focus on this piece for a little bit before we kind of dig into questions and back and forth. We ended up using two authorities, 1115 and in lieu of services. The 1115 was needed for our short-term post-hospitalization housing and recuperative for someone experiencing or at risk of homelessness to have the full continuum from discharge. And the others were in lieu of. And California is really large, as everyone knows, and we have rural parts, frontier parts, and urban parts. But we also know that these community supports that really allow for us to provide the whole service for very vulnerable populations, they don't exist everywhere across the state of California. And we needed time to build that up. So the in lieu of services authority within the federal regs gives you that flexibility to kind of incorporate it. Our managed care plans, they've never provided housing and homelessness services to a certain degree. They are just understanding how to do home modifications or medically supportive foods or to engage with sobering centers. We needed to build that capacity, that learning, those relationships over time. And when you add a stark new benefit, there's an expectation typically from the federal government, if it's an entitlement, that everybody has is available to that. You have a broad access across the entire state to achieve that. And we just weren't there in California. We wanted to build this. So we provided a lot of funding separate and apart to kind of motivate that change. Direct grants to providers, community-based organizations. This is the first time that they were going to be contracting with a managed care plan. That's significant change for a lot of people. And we needed to do that over time in phases. And so we're doing a phased approach to make sure we really work on the partnership between our community-based organizations, providers doing these various services in our managed care plan. So really, CalAIM is a really huge initiative. Today, I'm focusing comments around the enhanced care management community supports part. But it really is comprehensive around how do you provide whole person care services while changing the delivery system as well as financing to really bring in services and supports that could change the trajectory of someone's life and breaking down those walls of healthcare. So I look forward to the conversation today and digging into some of those details with you.
Thank you. That was it's a huge initiative and it's a lot to cover in a very short amount of time. So we're just almost scratching the surface. I did have just one follow-up question for you. And then audience, please chat your questions. We're going to make sure that we have 20 minutes at the end so we can have a dialogue with both Director Cooper and Director Snyder. So you talked a little bit about this already, the challenges that you anticipated, having to get people ready to partner with managed care organizations, not having the infrastructure and having to rely on the in-lieu services. When you think about some folks that may be listening in who haven't started this work or have started it and maybe not at such a scale as you're now embarking on in California, what are some of the challenges that you had to overcome, and what advice would you have for them as they think about where to go next?
The amount of technical assistance and collaboration, you cannot underestimate it. I mean, we are investing in California significant dollars to even broker these new relationships. And then the technical assistance of people speaking different language. Community-based organizations are not used to, not all, some are, not typically we're seeing used to billing in Medicaid rules, enrolling as a provider, negotiating a contract with a managed care plan, and in meeting our kind of broad-based Medicaid rules. Like the amount of technical assistance that's needed is real. And what we tell our managed care plans is just like you don't just go hire anyone to do surgery, you hire surgeons to do surgery. We don't want you to just go hire anybody to do housing and homelessness outreach, navigation services, deposits, and liaison services. We want you to hire subject matter experts that are embedded in that continuum, who know what they're doing, who are a part of that community, and who will be most effective to achieve the outcomes that we want. So it's reminding people that these are new relationships. And so you do have to provide a lot of technical assistance, time for collaboration locally so they can understand. And then in our perspective, you have to fund some of these providers. We're choosing to do that directly to them because there's a big shift that they have to add on administrative components that they never had to do before, reporting components that they didn't have to do before, training of their staff to understand. So it's a combination of those things that we've learned very quickly. We thought it was going to be important. We have learned over this last year of going live with many of these, how critical it is going to be to the long-term sustainability of fully embedding this in to our delivery system for the long run.
Yeah, thank you for that. I completely agree with your emphasis on the technical assistance piece and getting folks ready. So we're going to circle back and talk a little bit more about CalAIM in a minute or a couple minutes. And now I wanted to really turn to Director Snyder and to talk about Arizona's work. The Arizona Whole Person Care Initiative recognizes that nutritious food, affordable housing, transportation, economic opportunity, all of those things really drive health and well-being. And it's so exciting to see all the work that you've been doing for a number of years, but also your recent approval of your demonstration to support your Whole Person Care Initiative. Would love for you to tell us more about the initiative and kind of what your hopes are as you sort of move into this next phase.
Certainly. Well, our focus on whole person care really stemmed from a decade-long effort to enhance the quality of care offered to Arizona beneficiaries while also bending the healthcare cost curve. And our approach initially was really around integrating care at the health plan payer level and at the clinic location. And what we realized over time was that understanding of integrated care really needed to extend beyond clinical care to ensure that we're connecting individuals that we serve to needed social services and supports. And so we launched our Whole Person Care Initiative back in 2019, and we really focused on building upon efforts that were already underway. We're really fortunate in Arizona to receive a state appropriation each year to provide rental subsidies to approximately 2,500 members that we serve. So we wanted to capitalize on that effort and continue to look at our data and look at the impact that we could have when we stabilize individuals in housing long term. And in fact, when we look at our data, we see some pretty remarkable outcomes when we're able to house someone long term with Medicaid compensable wraparound supports. We saw a 31% reduction in ED utilization, 44% reduction in inpatient stays, and a savings of over $5,500 per member per month. So we definitely focused right out of the gate on housing. In addition, we really looked at transportation as one of those key social service supports that can assist individuals in connecting to job opportunities, connecting to healthy food. So really looking at building upon our existing benefit and encouraging individuals, for instance, to use bus passes, where they can use the bus pass on a monthly basis, not only to get to clinical care, but also to those needed social service supports. We also looked at the issue of social isolation. And again, we initiated our Whole Person Care Initiative back in 2019, when social isolation was certainly an issue, but not to the magnitude that we see today following the pandemic. And so really looking at building upon our existing habilitation benefit, in particular for young adults with disabilities that are having trouble connecting to the community, and offering peer support services to try to address those issues of social isolation. And also looking at technological supports like bot-based apps that can help address issues of social isolation for individuals with a designation of serious mental illness. So that really was the foundation of our request to CMS with our 1115 waiver renewal. And with our 1115 renewal, we focused on a few things. First, extending benefits that are already available in our program, like home modifications that have historically only been available to individuals in our long-term care program, as well as community transition supports, which can pay for things like first month's rent, basic furnishings, extending those benefits to a larger cross-section of our population, because we know that there's individuals that do not qualify for long-term care, but need those basic supports in order to be successful in independent living and permanent supportive housing long-term. Also looking at being able to reimburse for outreach to individuals experiencing homelessness. What our providers and our community stakeholders have told us is that outreach is absolutely critical, outreach and engagement, to ensuring that individuals ultimately access care and again are successful long-term in regularly accessing preventative care and successful and permanent supportive housing. And then finally, very similar to California's request, we asked for the ability to reimburse for up to 6 months of transitional housing, specifically for individuals leaving an institutional stay, whether that's a correctional setting, an inpatient stay, and focusing on the most vulnerable populations, individuals with an SMI designation, youth transitioning from the foster care or into adulthood that are in the foster care system, as well as individuals experiencing homelessness. And then finally, we asked for the ability to extend our targeted investments program, which is a program that we have supported over the course of the last 6 years under our prior waiver. And that program really provides incentive fundings to providers that are willing to invest in the infrastructure development to integrate care at the point of service. And now we're really extending our understanding again of what that integrated care model looks like within that clinic setting, to include offering social service supports. So through that program, we maintain 13 justice clinic sites, for instance, throughout the state, where we offer parole and probationer services, physical health services, behavioral health services, and medication-assisted treatment, as well as a variety of social service supports in that one clinic location. So we're really excited. We received approval of our waiver on October 14th of this year. So really just initiating the process of standing up the various components of the waiver. But again, we really see it as very much tied to that overarching effort around integrated care. And again, working to enhance the quality of care that's offered to members while also bending the cost curve.
Thank you, Jamie. And I have a follow-up question for you too, and then we will go to the broader set of questions from the audience. Just thinking about the time you've invested and really thinking about integration, I think has been a model, frankly, for other states. And your work that you really have engaged in for the number of years now, what would be your advice again to states who are just starting on this journey, similar to what I asked Director Cooper? What might you offer in terms of advice? What lessons learned you have and kind of where you're going next?
Director Cooper really hit the nail on the head. This kind of effort really requires, I think, an enhanced level of stakeholder engagement and a commitment to technical assistance really throughout the process. We've experienced some of the same challenges in connecting with non-traditional partners, specifically community-based organizations. And many of our CBOs have said very clearly to us, we don't want to become providers. We don't want to enroll with your program. We don't want to contract with health plans, and we don't want to bill for services. So to the degree that we can, offering financial support and technical assistance to those CBOs that aren't interested in becoming providers. For instance, we are in the process of standing up a closed loop referral system, community cares. So offering incentive funding to CBOs for their participation in community cares. And for those providers, like some of our providers in Arizona that have historically worked with individuals experiencing homelessness that are interested in enrolling, providing that hands-on technical assistance so they can better understand how to enroll with the program, how to effectively contract with managed care organizations, and how to bill for services. I just think that's really, really critical. And that work will continue well into the waiver period as additional parties come to the table and express interest in partnering with the program.
Thank you for that. And I think such an incredible, important piece of it is having the partners at the community level that are able to do this work. So thank you both for those opening remarks. We are going to open it up now to questions from the audience. I will field them, so you all don't need to look at the chat, directors. And audience, please chat in what you might want to hear about in more detail. So this is a question for both of you. How does self-direction play a role in integrated care in each of these programs? And I don't know who may want to start with that.
I'm happy to start.
Okay.
So, one of the pieces that we thought was really important to be required for both our enhanced care management program as well as the community supports is just being really transparent around the networks that will exist across. So we require that these networks are provided in the member handbook, for example. So let me just give you an example. Say there are 4 recuperative care providers or medical respite, people use different terms, provided in that particular county, giving beneficiaries or members the choice or understanding of those offerings is just as important as any other service that's being offered to an individual. And so the enhanced care manager who is working with them on a care plan for what this might look like, really making sure that they understand those pieces and that someone gets to choose if this is an option. They also can opt out of these services at any time. Opting into enhanced care management is something they elect to do, as well as any of the community supports that are being offered to them. And so we do think that's a really important piece in California, self-direction and making sure that our members, really are owning the care plan jointly with our care teams and the care managers and or those that are going to be providing the various community supports available to them.
And I would just echo that sentiment. I think it's really about ensuring that you have a really robust network of providers that individuals can select from. And again, to JC's point, ensuring that individuals are very involved in their care planning process. So they have the opportunity to select from among those providers, the provider that best meets their needs.
Yeah. Okay, next question. So this is for Director Cooper. How is California implementing the short-term post-transition housing piece? How will health plans engage with various housing partners?
Sure. So we have kind of 2 different pieces. We have what we call recuperative care or medical respite, and then we have the short-term post-hospitalization housing. For recuperative care, it's a 90-day transition or a benefit. And then for the short-term post-hospitalization, it's up to 6 months of kind of clinically directed housing. Both are available from release from an inpatient stay, from a skilled nursing facility stay, essentially building that continuum. And so making sure that upon admission into a hospital, for example, that there's immediate conversations within that team to identify someone as a candidate if they have an enhanced care manager, or assigning them within there to build that care plan to discharge them directly into a recuperative care or a short-term post-hospitalization if their medical needs, need that. If you imagine, someone can sit in an inpatient or a skilled nursing facility for far longer than needed because the clinical teams are nervous about discharging them to the street. So it really will come at those points of transition, such a critical component in regards to that. You also can build off of it, recruit to short term, so you can get a full 9 months out of that, depending on the circumstances, which is why I mentioned both, because I think it's important for people to understand how those things can work and build off of each other in certain circumstances. And really it's about tying then while they're in either the recuperative care or the short-term post-hospitalization, it's around building that care plan, connecting them then to the housing transition services. So having somebody in there who can get them a voucher and can get them into that housing. The idea is to just, continue the continuum across there. I would say though, in California, sometimes 9 months is not enough to get somebody connected into housing. It's just the reality of things here in California. So we're thinking about those options. We're thinking about how do we address that, and working very closely. And many of those recuperative care and short-term post-hospitalization housing providers are fully embedded into the full continuum of those housing and homelessness services. And really making sure that we are making those connections when we have somebody in a setting to build that trust, which is so important to then make it to that next step of housing. So that's how we're approaching it here in California.
That's great. I might ask a related question to Director Snyder, who also has been doing so much work on housing. So the transition of care, I think, is so important, making sure those people are supported throughout. Just thinking about like hospital discharge, how do you involve the health system, so they understand what to do with someone who's particularly complex and may be moving to homelessness upon discharge? And I might ask the same question of Director Cooper too, but I'll start with you, Director Snyder.
Certainly. And I think that's what in particular, the transitional housing benefit is meant to address in our waiver request, is ensuring that there is an appropriate placement where we can stabilize individuals clinically, connect them to needed social service supports before transitioning to permanent supportive housing. But I'll go back to something that JC said earlier. I think there really needs to be a recognition at every level of the delivery system that the work that we're doing under these waivers is different than the work we've done before. And we really need to ensure that, particularly over the course of those transitions that can be really challenging, that we have the appropriate expertise on board at the agency level, at the health plan level, and at the provider level to ensure a successful transition. So that means really extending expertise beyond clinical care, beyond those traditional services and supports, and having individuals that understand permanent supportive housing and how it works in the real world. And it's not just about the rental subsidy. It's not just about the Medicaid compensable wraparound services. It's about combining those two resources and ensuring that the individual is able to maximize those resources so that they can be successful.
Yeah.
But I really can't stress enough that I think it's a little bit of a new world for us, and we all have to commit to bringing the right expertise in-house so that we can be successful.
Great, thank you. A question for both of you. So it looks like we're getting closer to the end of the public health emergency. Looks like perhaps in April, depending on where Congress lands in this latest negotiation. Wanted to ask a question for both of you. How do you think these programs will evolve after the end of the PHE? Will it have an impact? What might be challenges? What might be things that could be helpful?
I'm happy to
kick that off.
Stab at it first. Well, I think it's a really interesting question. And I think it actually ties back to a larger question about what is the Medicaid program's role in supporting and advancing social services. I think it's an important question that we need to continue to discuss. I think the work that we're doing in Arizona and the work that JC is doing in California really does serve that core purpose of enhancing the quality of care that we offer to our beneficiaries while also working to bend the cost curve. But I also think we need to keep our eye on that understanding of sort of the collective impact model and continuing to partner with some of our sister state agencies, other community partners that bring like resources to the table and ensure that we're staying in our lane while also maximizing the benefits that we can bring to the table through the federal state partnership that we promote with Medicaid programs. And so it'll be interesting to see how things evolve after the end of the PHE. As you mentioned, Hemi, we are now anticipating that it's going to come to a close in April. We'll see how that plays out. But I think one of the things I would say about both of our programs in Arizona and California is we are going to be effectively implementing these large-scale waiver opportunities at the same time that we're reinitiating our standard redetermination protocol. So it's just something I think for stakeholders to keep in mind. So we're balancing those two major efforts, and both of which are equally important, that we're really going to need their partnership and their support so that we can be successful on both fronts.
Yeah, no, I really agree with everything Jamie said. And one thing I will say is I have stopped predicting when the public health emergency will end. But yes, I think one of the other things, in addition to what Jamie just mentioned, huge things happening at the same time, is hopefully, at least with enhanced care management in California going out, this is about somebody who's going to be able to help someone who's the most vulnerable, right? We are with these services, they're going to be in environments, facilities, working with community-based organizations, providers, or enhanced care management teams that can really ensure that they get their redetermination done. So if you think about it from that perspective, right, your most vulnerable are going to be in these, receiving these services and supports or getting this additional help and services. And so really making sure that we make it an expectation that any of our providers, community-based organizations working with these populations are going above and beyond and out of their way to ensure that all of our Medicaid beneficiaries understand what the redetermination is, that they get their packet, they need to act on it this time, even if they acted on it last time, making sure that they're getting that information in so that they don't lose coverage, especially so they don't lose these critical services and supports that they need in order to just like Jamie said, whether it's stay out of an emergency room, back being admitted into a hospital or in a skilled nursing facility, all of these services and supports that we're providing are preventing some higher level, higher cost, more acute setting, right? And so keeping people in the community safely where they can and keeping these supports is so important. We don't want them to lose them though. And so that's why reminding them that, keeping, reapplying will be really important so you don't lose these critical supports, and really relying on our community-based organizations and our care managers to help really carry that message and help them finish their packets during the public health emergency unwinding will be so critical for some of these populations.
Yeah, that's a great point about, having additional trusted partners who can reach folks to make sure they understand what's happening and what they need to do. Great point. Silver lining, hopefully, as you look to do what you need to do with redeterminations. I think, JC, I saw that California is almost at 15 million now of enrollees. So that's a lot of people on Medicaid. Okay, another question for both of you. How have you addressed some of the structural inequities, such as power, decision-making, funding that exist within your state and the healthcare system at large? And how can these programs help address those inequities?
And I would just argue that these programs, they're very much about addressing health disparities that exist in our respective states. One thing I did want to mention, both California and Arizona have additional requests on the table in front of CMS that are focused on addressing health disparities. And those include requests around traditional healing for individuals on our tribal lands, as well as requests for reach-in services for individuals leaving correctional settings. Both really important requests. I know we're kind of arm in arm working with CMS at this point to get those over the finish line, but I think they're both a nice complement to the work that we've described today during our webinar.
Yeah, no, I agree with you, Jamie. And yes, we are actively working on getting those things across the finish line. I agree with you. We've been great partners in that way. I think, it's very clear to us when we look at the various disparities that exist in California. Just take the justice initiative that Jamie just mentioned. We know that Black and Latino individuals are incarcerated at a higher rate than the general population. So they are, the disparities are real. And we do think that many of these services and supports, even, for example, again, in California, the number of people experiencing homelessness is proportionately higher on Black individuals, right? So this is a targeted approach of making sure that we are looking at social drivers of health to be a targeted way of closing disparities within our health system, and to address them head on, and be very intentional about it, to be honest with you. Including in California, we have an incentive program with our managed care plans to make sure that they are implementing the various components of CalAIM. And one of our direct incentives to them is to make sure that they are breaking down all of their services by race, ethnicity, language, etc., so that they are aware of where there are gaps in regards to their delivery and approach. And then we even went as far as being very directive of an incentive program around ensuring that they are targeting people who are experiencing homelessness and who are Black African Americans, to ensure that we are doing what we can to be very clear around closing some of these gaps. And so I think it is very much what many of these programs are focused on, and making sure that we are bringing those tangible solutions, and in California being very intentional about that.
And I was going to mention, Hemi, as well. It's the case in Arizona. I imagine it's the case in California as well. Our waiver evaluation actually includes metrics where we look at the degree to which the initiatives that we're advancing are addressing health disparities. So I was thrilled to see the administration double down on that commitment as well.
Yeah. And so important, so you can actually see the impact of what you all are undertaking. Okay, this is going to be the last question. Then we're going to move to close the webinar. So this is an interesting one. So what one solution or innovation do you wish to see expanded on in the next 5 years for Medicaid? You're embarking on a whole bunch of new ideas, but is there one that you want to see move forward in the future that isn't already? Jamie, why don't we start with you?
Sure. I mean, for Arizona, we've had the, I guess, luxury or the privilege of doing a lot of work in the housing space. So again, we have data that really shows that we can have a pretty remarkable impact when we house someone long-term and permanent supportive housing. So clearly the administration, the current administration, kudos to them for recognizing that it's important to invest in shorter term transitional housing. I think going forward, I think there's an opportunity to talk about whether it makes sense for Medicaid programs to also invest in longer term permanent supportive housing, again, with those Medicaid compensable wraparound supports. We have a lot of really good data to support the impact that we can have from a health outcome standpoint when we house someone long-term for 6 months or longer. And so I think we have a compelling case to make, and I'm hopeful that we can have additional conversation with the administration about that sort of effort going forward.
Okay, thank you. JC.
Yeah, so I think there's kind of two big pieces, and it's kind of how we're, at the beginning, I talked about one of the key components of CalAIM is breaking down the walls of healthcare. And I say that because if healthcare was working as it's currently constructed for people, we wouldn't have the quality scores in many of the pieces that we're all doing here. So I think there's two pieces to that. There's a workforce component and there's a population kind of management component. I think from the workforce, I think, we're wanting to really push the needle in regards to how we think about access. and thinking about it in ways that incorporates a lot larger number of non-clinical teams on the healthcare side and the role that they play in healthcare and our ability. As we all know, many of us are having workforce shortages across the entire nation, including just our ability to retain and recruit and hire clinical staff at all levels. Especially on the behavioral health side. So really pushing the needle in regards to the long-standing expectations of a clinical approach in the medical world and bringing in more non-clinical touches to augment that workforce to really make sure people are only needing the touch at the appropriate level when someone really needs to see a physician versus the other various pieces. And I think there are some long-standing federal regs that maybe we can push the limits on a little bit here as we broach our new world in the next decade. And in that same vein, really thinking about the role communities and populations play. You know, public health departments have done this forever and they do it well, but how do we start actually going back to bringing the public health approach with the medical and health delivery sides together to really start thinking about things from a population approach in our communities, which means that you may be paying for things that are not Medicaid, but if the dominant community is almost 85–90% Medicaid based, you know, how are you thinking about funding from a population approach to kind of move the needle in very vulnerable communities across, you know, sectors, states, et cetera. So I think those are two spaces where this work that we're doing on bringing the social world together is going to push limits on workforce. It's going to push limits on approaches of kind of longstanding silos of funding and or relationships, even at the federal level as well. So I think those are two I'd throw out there.
Yes, very insightful. So I wanted to thank both of you, not just for being here on this webinar, but really your leadership in this work. It's not easy, but so important. And I'll just say personally, I think, you know, we're trying to work within a healthcare system that was designed a certain way, right? It was designed for clinical care paid on a fee-for-service basis. And as we really think about a different way of approaching it, you're pushing back and trying to think about how to creatively restructure the way our system was originally built. So it's a lot of work, and I can't underscore how important the cross-sector pieces are to all of what you're doing. Housing, food, transportation, all these pieces, right, that are being funded from different places that from like originally from the federal government, now at the state level. So thank you for your innovation and your steps towards changing our system. Before you all go, audience, please take a moment to complete the brief survey that was chatted. And we hope you'll join us on January 10th as we continue this Medicaid Innovation Award discussion with Medicaid leaders from West Virginia and Kentucky. A link to register for that event is being shared in the chat, and we'll be sure to include it in the post-event email you'll receive. So thank you again. I think we've learned so much, just scratching the surface in 45 minutes. But there are fact sheets that have been shared, so you all can learn more about the programs in Arizona and California. And want to thank all of you for joining us, and thank you to the Robert Wood Johnson Foundation for supporting the Medicaid Innovation Award. It makes me so happy to share innovations from other states more broadly and have people learn. That's how we change the world, right? So with that, I'm wishing all of you a very happy holidays and a happy new year. Take care, everybody.